First, a sincere thank you for inviting me. It's a real honor to be a part of this webinar. And my assigned topic today is technology in the ASC, cost versus value. But it was really the subtitle that caught my attention: Robotics, PSI, Disposable Instruments. I am a consultant for Stryker. I also work with Avail and OSO-VR in various capacities. As it's a tech conference, I started with ChatGPT and asked it to discuss cost versus value with technology in the ASC. The answer was pretty good. It said it was a balance of cost and benefit. Talked about three things: patient outcomes, operational efficiencies, and financial performance. You may not know this about ChatGPT, but if you don't like the answer, you can just ask for another answer. And when I did that, it changed the terms around. Now it talks about the balance of cost and value, but replaces financial performance with reduced cost in the long term. That's a challenge for our ASCs because we're focused more on the episode of care. But one more chance for ChatGPT to frame our discussion. It talked about the balance of cost and value, but ultimately it encouraged all of us to ensure that the investment aligns with the ASC's goals and missions. What is our goal in our ASC? What is the mission of our ASC? One goal must be to provide value and be a center of excellence. We as surgeons turn to our industry partners and ask for better tools to execute our surgeries, and they deliver. I pulled one graph that illustrates technology can execute better on the surgeon's plan. I know some people are stating we don't really know where the target is, where that box is for each individual patient. And I don't disagree. The spinopelvic relationship is complicated, but we can agree upon this, that the Lewinix safe zone is not safe, and that just because a spine is instrumented doesn't necessarily mean it's stiff. It was Larry Dorr that showed us that of the impingement that we see, 75% is bony. That could certainly lead to dislocation, but also cause pain. How do we find the individual plan in which to therefore execute for each patient? Technology can help us here. This system uses a preoperative CT scan as well as a standing and sitting spine film to define the position and the relationship. You can take each patient through an individual virtual range of motion to see where the impingement is. Here, 90 degrees of flexion, internal rotation produces bony impingement, and you can see some component impingement with the extremes of extension and external rotation. You can individualize a plan and hit your specific target as illustrated here in a recent paper out of HSS. But how do we place value upon that opportunity? That can be more challenging. I was doing some research outside of medicine, ran across this graph talking about price and cost. Notice here that value has no direct monetary measurement. There are certainly ways to reduce costs. Here's some options to reduce costs with knee replacement. You could use a universal knee system, no lefts, no rights. You could use an all-poly tibia. You could stop resurfacing patellas. Some of you do this. I hope it's not to save time, but every study has showed increased reoperation. Well, who is responsible for that increased cost? It's certainly not the ASC. Manual instrumentations, which are consigned, spinal blocks. How about this for saving cost? No regional blocks, no periarticular injections. Staples are cheaper than how we close with a deep dermal. Certainly there's ways to decrease costs, but even if I show you technology that reduces soft tissue damage, reduces narcotic use, speeds up inpatient care, that even leads to less physical therapy and less pain for the patient, how do you add a value measurement to that? It can be quite difficult. What if we framed value around executing the surgeon's plan? There's been a lot of discussion in knee replacement for years around alignment. We can argue about mechanical versus kinematic alignment, but there's so much emphasis now around ligament balance and stability of the overall construct. It's probably why there's more emphasis in the medial pivot knee now, increased constraint for stability. But how is technology going to allow the surgeon to execute on their individual plan for their individual patient? This is how it happens. You can make adjustments through bone. Adjustments through bone are precise and titratable. You have better information and better ways to execute that bony plan to lead to balance and stability versus prior techniques where we would titrate the soft tissue for balance. Now, this is largely imprecise, and we have all experienced that. There are systems that allow you to offer value to your patients and empower your surgeons to deliver great value by executing a better plan. Each system has many things to consider, like what is their footprint? What is their portability? How many systems do you need? One that moves room to room? Do you need multiple if you're running multiple rooms? And what about ongoing support? Some of these technologies offer ongoing support as specialists in the room. Maybe you see that there's value in that play. These are the things that we must talk about around value when you look at each individual technology. There's cost savings when we talk about decreasing instrument turnover and the necessary inventory, especially in those products that allow for preoperative imaging. What about capital cost? Thankfully, now there's models where you don't have to just outright pay money up front. You can instead do leasing programs or something called joint value, meaning if you increase your volumes, and that's certainly happening in the ASCs, you can actually pay off the capital equipment over time. We need to also mention disposables. Be real careful as you look at these technologies about the cost of the disposables for each case. You need to know the cost. You need to explore bundles and capitated pricing and even rebates from companies. At our institution, we utilize rebates based on total spend from that company for the whole case. At the end of the year, based on volume metrics, they essentially rebate us back a percentage or total spend, which comes to approximately our cost of disposables. I've been careful not to mention this equation, but value is quality over cost. We've talked about the difficulty of assigning value to certain things. Certainly we can reduce costs, but that's not necessarily a good thing. One thing that I'd mention as I close, there is certainly a cost to an empty OR room. There's a marketing element here, and we want to draw patients into our ASC because we can calculate the cost of an empty OR, and it's expensive. Hopefully, I will be on the webinar a little bit later to engage a little bit more personally through a discussion. Thank you for your time.